This conference will now be recorded.
Hello everyone. A warm welcome to our MFDS Part 1 Session 3. By CM Dental Academy. It's an online dental education platform in the field of dental surgery. We aim at delivering excellent quality online training programs and courses for dental students under the guidance of eminent mentors. The subjects will be covered in all the formats such as live lectures, descriptive notes, MCQs, and Viva Voice questions. So, what are you waiting for? Come, let's begin a journey towards success. In today's session, I'll be covering restorative dentistry pertaining to repairing teeth. The highlights being repair and replacement of teeth, management planning, dental pain, occlusion, team working, isolation and moisture control, principles of operative procedures, posterior composite restorations, indirect resin composite or porcelain inlays or onlays, and posterior amalgam restorations. Repair and replacement of teeth. Increasingly, the approach is tending towards the biological concept of management rather than the mechanistic that before we used the drill and fill philosophy. Dental tissues may be damaged by mainly the caries, trauma, or tooth wear or tooth surface loss, maybe due to some developmental defects or abnormalities of the tooth structure. So, in such conditions, patients will present with the pain or sensitivity. Many a times, the approach towards these causes will be drill and fill was used till now, but recently the approach is being more towards the biological concept. The approach is tending towards the biological concept of management rather than the mechanistic. This is important as a population lives longer and teeth are retained longer. As soon as the restoration is placed, there is entry into a cycle of replacement, with ever more destructive restorations inevitable over a lifetime. This is sometimes referred to as a restorative escalator, with the patient moving closer to losing the tooth with each restoration. A minimally invasive approach, whenever possible, is therefore important. When there is a total loss of tooth in such cases or cannot save the tooth, then replacement with the fixed partial dentures or removable prosthodontics, incorporating indirect or laboratory made prostheses can also be used. Management and planning. It is dependent mainly on the thorough information regarding the history of the presenting complaint, what patient complaints of main patient concern is, and also medical history equally important along with the dental history and social history. Followed by the history, detailed examination of the patient, such as for any general examination, any pallor or disability or any facial asymmetry or gross extraoral or intraoral, any swellings are present in not only in and around the oral cavity, also head and neck region also stands. In intraoral examinations, examination of the mouth, especially including the soft tissues, periodontal tissues, teeth, and at most important being the occlusion. And any patient is wearing any prosthesis. For complex cases, mounted study models or diagnostic wax up should be considered. Sometimes Facebook record may be required, particularly if there is not a reproducible occlusion. Occlusion is such a factor that even if you're going for a restoration or any prosthesis, even for the artificial prosthesis like complete total extraction of the teeth and replacement with the removable partial denture or fixed partial denture, it plays a key role. So recording the pre-operative records is very important for the patient, which will decide the end results and the patient satisfaction post the treatment. And also relevant special investigations such as if any radiographs are required for during the diagnosis or examination, and sensibility testing or the pulp testing, if it is required, it has to be performed. Then risk or susceptibility for caries and tooth wear can be identified. What is the cause for the increased incidence of the dental caries, or what is the cause for the tooth wear, whether it is normal physiological process or patient is having any other conditions associated with, or any temporomandibular joint disorders involved, or patients has a bruxism or night grinding of the teeth. All these factors have to be taken into consideration before the recording. This process of recording or the examination of the patient is called as targeted verbal history. Irregular attender or frequent sugar intake regarding the diet has to be recorded. It will help us in assessing the increased incidence of caries in the patient. Even the eating disorder, if patient is suffering from any clenching or grinding habits. The clinical evidence such as patient's oral hygiene condition and any other lesions or any other abnormalities such as any mesenteric hypertrophy and any disorders associated with the temporomandibular joint. After this, then staging of the carious lesion have to be performed using international caries detection and assessment system. Consideration of caries risk factors have to be explained to the patient, why the patient is more prone for the caries or increased incidence of the caries. Radiographic examination allows best management option to be chosen. It will give you the exact detailed idea regarding till what is the depth of the caries, where it has penetrated, whether it is only involving the enamel, whether it has reached the dentine and pulp, what has to be the treatment following the respective layers. So always radiographs and any other collateral investigations required have to be conducted. For deeper sections, radiograph or any in case of radiographs, artifacts or burnouts also lead sometimes false positive diagnosis that needs to be taken into consideration. Under ideal circumstances, an integrated management plan is formulated for each patient at the start. Once all the diagnostic procedures have been performed, patient thorough examination is conducted, then one ideal treatment plan has to be formulated for the patient. The plan will need to be revised in the light of clinical findings as care progression. For example, patient cooperation has to be taken into consideration, a response to the periodontal therapy for this thorough assessment of the periodontal condition, patient oral hygiene habits, and patient's approach towards maintaining the oral hygiene. These are all the factors to be looked for. When dealing with the patients with a range of problems, it is therefore wise to formulate a plan which is number of achievable goals. So formulation of a plan with number of achievable goals depends on these factors. What are the sequence of treatment? Once all the examination is performed, all the diagnostic methods are performed, how to approach the patient for the treatment? First and utmost goal for the treatment to begin with is going to be the relief of the pain with which patient complains of it. If at all, if this is going to be the patient's chief complaint, always caregiver should concentrate mainly on relief of the pain. Then control of active disease. Once the patient is relieved of the pain, how to control the active disease? What is the cause for this disease have to be targeted, and achievement of the stability. These two are the main basic keys to be achieved once we begin with the treatment. In case of low caries risk patients, oral hygiene instructions and dietary modifications and topical fluoride application have to be conducted. If the patient is really high caries risk, along with these, that is oral hygiene instructions, a dietary modification and topical fluoride, addition of professional tooth cleaning like ultrasound scaling, stabilizing restorations if required, high concentration toothpaste containing fluoride 2800 to 5000 ppm, then fluoride mouth rinses in patients above 8 years of the age. Sometimes professionally applied fluoride varnish, topical remineralizing agents, and management of hyposalivation, fissure sealants, and sealants for restoration can also be advised in case of patients with high caries risk. So these are the approaches pertaining to the patient's complaints. There is evidence of sealing of non-cavitated occlusal carious lesions even when there is radiolucency extending up to 1/3 of the way into the dentine. Patients with risk of tooth wear. In this, modification of behavior to remove etiological factors stands first priority, then considering the provision of protective splint. In case of initial periodontal therapy, then extraction of unsavable tooth with the compromised periodontal health of if the patient complains with the mobility, then extraction is most advisable treatment for such patients. In patients with multiple carious lesions, it may take several weeks or months to complete the entire treatment of all the teeth affected with the caries with the restorations and to secure a good oral health. In these cases, it may be advisable to prevent any symptomless large lesions increase in size by placing temporary dressings. The cavities should be rendered caries-free at the margins and temporarily restored with the cement, such as glass ionomer cement. Consideration of definitive denture designs if at all required, and remaining simple restorations. Any indications for root canal treatment can also be looked for. Reassessment of the success of initial treatment, such as oral hygiene instructions, periodontal condition, and progression of the health. The reassessment of these treatment options in patient is also required by the clinician so that it will help to keep a track and a follow-up of the patient's improvement of oral health. In case of definitive treatment, such as crowns, bridge work, dentures, and implants, and monitoring at intervals appropriate to level of risk. If the patient's disease is in a good healing phase and recovering phase, or whether the condition is worsening or it is further entering into the worst phase, this will help if we keep follow-up intervals at a regular period of time. So practical points also need to be taken into consideration, such as listening to patients inquire as to whether what it will help us to understand what are the patient's expectations and what are the priorities before beginning with the treatment. Discussing the management plan with them and the role they will have to play in controlling their dental diseases. Once a thorough treatment plan is formulated, a clinician should discuss the treatment plan with the patient so that patient will also be cooperative and familiar with the treatment going to be performed. And success is dependent upon the patient compliance. Therefore, time spent actively discussing their expectations, treatment options, time involved, cost implications present and future, and their role in maintenance is invaluable. It is important to bear in mind subsequent items on treatment plan. For example, design of a particular partial upper denture may influence the choice of material and contour of direct or indirect restorations. For individual tooth, or what all, if at all it needs a treatment, what is going to be the treatment for this, what type of material is going to be used, and what are the end results, and how patients should cooperate, how many settings are going to be required, what is going to be the cost of it. All these detailed factors have to be discussed with the patients in detail. For complex cases, several short treatment plans, each ending with a reassessment, are more logical and efficient. When formulating treatment, group items together into appointments to form a visit plan. Consider the time needed for each visit and anesthetic requirements. So if patient needs a few minor treatment procedures, so all those minor treatment options can also be clubbed in one appointment and can be performed on the same appointment. It will also help to reduce the patient's appointments, also appointment visits, and also it is less time consuming for the clinician also. Record keeping is very important. At the end of each appointment, carefully note what has been done and the material used. This is going to be very important. It will help to be familiar with the clinician and also the patient even after the treatment is being performed, and even if you want to take any refer any medical or dental history in future also, this will be helpful. It is important to recognize your own limitations and where appropriate, refer in case of any challenges or any limitations. It is always advisable to refer patients to the higher centers or for the treatment. So these are the practical points to be taken into consideration in management of a treatment in dental clinics. Dental pain. When a patient attends a surgery complaining of the toothache or pain, it may be arising from variety of different conditions, such as it could be a pulpal pain, mainly arising from the pulp tissue, or periapical pain, that is same the pulpal pain extending into the periapex, that is the surrounding tissue, and or the periradicular pain. And pain sometimes also could be due to the non-dental pain or non-odontogenic pain, which is not at all related to the tooth or tooth-bearing areas, such as from the adjacent structures. Might be some muscle hypertrophy or dystrophy, or it also could be due to the any abnormalities in temporomandibular joint or muscles of mastication or Mfds, like this. So pulpal pain, it occurs mainly due to the bacterial, thermal, chemical, traumatic insults to the pulp tissue. It leads to the pulpitis. In such conditions, vitality testing or sensitivity testing is performed to check whether pulp is vital or non-vital. Only the 100% accurate method to study the pulpal vitality is going to be the histologic sections. Reversible pulpitis and irreversible pulpitis. These are the very commonly encountered conditions in day-to-day practice. So reversible pulpitis presents with fleeting sensitivity, pain, or to hot, cold, or sweet with immediate onset. It is usually sharp and may be difficult to locate, quickly subsides after the removal of the stimulus. There will be exaggerated response to pulp testing. Carious cavity or leaky restorations presence will be there. Tooth not tender to percussion. Treatment is always going to be remove any caries present and restore or replace sedative dressings such as zinc oxide eugenol paste or permanent restoration with suitable pulp protection for reversible pulpitis. In case of irreversible pulpitis, it presents with spontaneous dull throbbing pain, which lasts several minutes or hours, and it is worst at the night and often pulsatile in nature. Pain exacerbated by hot and cold. In later stages, cold actually is the symptom. Characteristic feature is that pain remains even after the removal of the stimulus. This is going to be the differentiating feature of irreversible pulpitis compared to the reversible pulpitis. Localization of pain may be difficult initially. Sometimes patient will be complaining of diffused pain and fails to locate the pain exactly. So as the inflammation spreads to the periapical tissues, the tooth will become more sensitive to percussion. Application of heat, such as using the gatapacha, warm gatapacha, elicits the pain. It presents with affected tooth, gives exaggerated or reduced or no response to an electric pulp tester. So it presents variously. In the later stages, it may become tender to percussion. So treatment follows extirpation of the pulp, and root canal is the choice of treatment for such tooth. If the time is short, in case of emergency, if patient cannot make it for a longer time to complete the entire procedure required, anesthesia proves elusive, then removal of the coronal pulp and an odonto paste or leather mix dressing can often control the symptoms until remaining pulp can be extirpated, and under the local anesthesia is going to be the ideal treatment choice. Dentine hypersensitivity. This is the pain arising from the exposed dentine in response to thermal, tactile, or osmotic stimulus. Due to dentinal fluid movement, it occurs, stimulating the pulpal pain receptors. It elicits the pain. Prevalence is approximately 1:7 adults, with peak reported in young adults due to erosions and dentine exposure, and around 30 to 40 years of the age. About 25 to 30% of the adult population report dentine hypersensitivity. It involves decreased etiological factors such as oral hygiene instructions, possibly including toothbrushing technique and intrinsic and extrinsic dental erosion. And by decreasing the permeability of the dentinal tubules, for example, by toothpaste containing strontium and potassium salts and or fluoride, placement of varnishes, dentine desensitizers, and dentine adhesive systems so that it will form again a protective layer over the already worn out dentine, and if indicated, a restoration is required to achieve the reduce the pain or the sensitivity in case of dentinal sensitivity. Cracked tooth syndrome. Patient complains of a pain on biting. To examine this, just a cotton wool roll can be placed and asking the patient to bite on it. Once the patient bites on it, there will be a presence of pain. It is of short duration and it keys on release of the bite or the pressure and possible to cold sensitivity. Some patients find pain elicited on sudden release of bite, so they present variedly. Tooth often has a large restoration most of the time, may not be apparent at first, but transillumination and possibly removal of the restoration may show the crack line. There is a positive response to vitality testing, and association with bruxism habit also been reported. And treatment involves an adhesive resin composite restoration with a cuspal coverage may be appropriate in teeth which are minimally restored, but in some cases, as in direct restoration with full occlusal coverage will be needed. Occasionally, root canal may be required, or as a last resort, extraction. Placement of an orthodontic band around the tooth can relieve the symptoms and help with the diagnosis. While there is a confusion regarding exactly to locate the pain, orthodontic band can be placed around the tooth. Once the symptoms subsides, then we can just locate the which is the culprit. Occlusal overload. It presents with pain on biting, which can be sharp and of short duration, but can linger as a ache. Often combined with instantaneous hot and cold sensitivity, tooth may become mobile. Check for the exclusive movements of the occlusion to see if tooth is taking guidance or where there are any few remaining occluding units. So occlusion has to be taken into consideration and it should be checked. Look for wear facets indicating bruxism. For treatment, soft splint for nocturnal use initially. Pain may take some time to settle. If pain persists, check tooth is not cracked or another any diagnosis. Usually it ends up like association with the cracked tooth once too much occlusal pressure has been applied onto the tooth. So we have to just rule out the cracked tooth syndrome also. Periapical or periradicular pain. In case of pulpal necrosis with periapical periodontitis, it presents with patient complaints with variable, generally describe a dull ache exacerbated by biting on the tooth. Usually no response to sensitivity such as the vitality testing unless one canal of multi-rooted tooth is still vital. So this is not very accurate. The tooth will be tender to percussion. Radiographically, there may be loss of lamina dura in the periapical region. The apical periodontal ligament may be widened or may be periapical radiolucency presence. It might indicate a granuloma or a cyst. In such situations, treatment is going to be definitely root canal treatment if prognosis of the tooth is going to be poor in case of when you take the factors into consideration such as the surrounding periodontal tissue and the presence of the lesion, likely the granuloma or cyst, which compromise the treatment outcome. In such situations, extraction is going to be the ultimate treatment option. Acute periapical abscess. In this condition, patient complains with a pain which will disturb the sleep, very acute pain, and the tooth is exquisitely tender to touch. Affected tooth is usually extruded from the socket because there will be accumulation of the pus in the periapical region. It will slightly extrude the tooth from its socket. Even patient may complain of pain in such conditions on biting. There will be presence of mobility and tender to percussion. It may be associated with intraoral and facial swelling also, or with a more localized intraoral swelling. So sensitivity tests may be misleading because of pus may conduct stimulus to the apical tissues. Radiographic changes can range from widening of the apical periodontal space to an obvious radiolucency. It is important to differentiate this condition from periodontal abscess. There are differences such as based on the location and the causes and also the symptoms. Usually no response to sensitivity or vitality testing. Treatment is going to be the draining out the pus. If indicated, relieve the occlusion so that as the tooth will be extruded from the socket, patient complains of pain. In such situations, first and foremost thing is going to be the draining the pus and relieving the occlusion. Drainage of the pus can often be achieved by entering the pulp chamber with a high-speed diamond burr or steadying the tooth with a finger to prevent excessive vibration. Even the vibrations will elicit the pain. After drainage has been achieved, it is preferable to prepare the canal and place a temporary dressing. Avoid open drainage. If possible, absolute or necessary for more than around 24 hours. After this time, further bacterial contamination of the root canal makes subsequent RCT very difficult. If a fluctuant soft tissue swelling is present, then it should be incised to achieve the drainage. Antibiotics should be prescribed if there is systemic involvement or the infection is spreading significantly along the tissue planes. When the accused symptoms have subsided, root canal treatment is going to be the ultimate treatment and to be performed if considering all the factors are normal. And if the tooth is going to be present with the poor prognosis, extraction is going to be the treatment modality. Lateral periodontal abscess. Similar to periapical abscess with the acute pain and tenderness and often associated with the bad taste. These are going to be the symptoms of the lateral periodontal abscess. In this case, tooth is usually mobile and tender to percussion with the localized or the diffuse swelling of the adjacent periodontium. Deep periodontal pocket is usually associated, which will exude pus or on probing. Radiograph shows vertical or horizontal bone loss and vitality testing is usually positive. unless there is an associated endodontic problem. So rule out the non-dental pain as well. In this case, achieving the drainage of the pus is the first goal. Irrigate with the chlorhexidine solution. If there is systemic involvement or recurrent problem, antibiotics are required. Combination of metronidazole and amoxicillin is prescribed usually. Debride the pocket once acute symptoms have settled. Extraction may be indicated if prognosis of the tooth is poor. Occlusion. Ideal occlusion is anatomically perfect occlusion, which is rare to find. In case of functional occlusion, it is the free of interferences of smooth gliding movements of the mandible with absence of pathology. Balanced occlusion is the one in all exclusions of mandible to provide increased stability of full upper and lower dentures, not applicable to natural dentition. Rarely in case of the full mouth reconstruction. Group function is multiple tooth contacts on working side during lateral excursions, but no contact on non-working side. These are just the key points which are very important to study, record during the occlusion. I have just listed them. Occlusion is going to be the very vast topic and has many aspects to be discussed. I have just enlisted few of the occlusion points here, which you can go through. Canine guided occlusion is the one during the lateral excursions. There is a discussion of all the teeth on the working side except for the canine and no contacts on the non-working side. Hinge axis, it is the rotation of the condyles during the first few millimeters of the mandibular opening. Terminal hinge axis, it is the rotation of the mandible when condyles are in their most superior position in the glenoid fossa. Retruded arc of closure, when mandible with the condyles rotating about the terminal hinge axis. Anterior guidance, it is a functional relationship between the maxillary and the mandibular teeth. It consists of the horizontal overlap of anterior teeth, that is the overjet, and vertical overlap, that is the overbite. Retruded contact position or centric relation. It is the position of the mandible where initial tooth contact occurs on the retruded arc of closure. It occurs when the condyles are fully seated in glenoid fossa. In approximately 10% of patients, retruded contact position and intruded intercuspal position are coincident. The remainder have forward slide from RCP and ICP. The rest position is a habitual postural position of the mandible when the patient is relaxed with the condyles in a neutral position. Previous space, it is the difference between the rest and intercuspal position. Centric stops, points on the occlusal surface which meet with the opposing tooth in ICP. There are normally the cusp tips, marginal ridges, and central fossae. Supporting or functional cusps. The cusps that occlude with the centric stops on the opposing tooth, usually palatal on upper and buccal on the lower. Intercuspal position or the centric occlusion, it is the position of maximum interdigitation. The non-supporting cusps that do not occlude with the opposing teeth, usually the buccal on upper and lingual on the lower. Deflective contacts deflect mandible from natural path of closure. Interferences contacts that hinder the smooth excursive movements of the mandible. Occlusal vertical dimension, it is the relationship between maxilla and mandible in case of intercuspal position, that is face height. As you all are familiar with the most commonly used words during recording the occlusion in case of all the restorative procedures or fabricating the partial dentures or the complete dentures. Now, how the thorough examination, occlusal examination has to be carried out to deal with the patient. Prior to carrying out restorative treatment, it is important to examine the patient's occlusion, the pre-operative records. The contacts can be identified with 8 micrometer metal foil and marked using thin articulating paper. This is nothing but just the recording the contact points before performing any kind of treatment. Important features to look for are the number and distribution of occluding teeth. Have to be recorded. Over eruption, any rotations, like any tilting of the teeth have to be recorded. Presence or absence of centric stops, the RCP and any slide between the retruded arc of closure and such as a retruded contact position and intracuspal position have to be recorded. Anterior guidance, lateral excursions, TMJ and muscles of mastication. Occlusal analysis or a diagnostic mounting has also to be taken into consideration. In most situations, restorations are made to conform to the patient's existing occlusion, and the main consideration is to prevent the introduction of iatrogenic occlusal interferences. It is known as conformative approach. It has to be followed. In some circumstances, the conformative approach is not appropriate and a new occlusal scheme must be planned whenever the patient is not comfortable with the existing occlusion. In such situations, a new approach have to be planned. This is often the case when extensive crown and bridge work is required, and patient's existing occlusion will be effectively destroyed by the preparations. A new occlusion is established, free of interferences over the patient occluding in retruded contact position, which is the only reproducible position. Approach is to treatment is called as the recognized approach. Generally, for simple intraoral restorations, complex methods are not needed, but care has to be taken to ensure the correct occlusal scheme is reproduced once the treatment is completed. Before preparing tooth, it is worthwhile making the centric stops with the articulating paper and trying to preserve them if possible. On completion of the restoration, it must be checked in intracuspal position to ensure that it is not high, but also to ensure that it has recreated the centric stops. Once the restoration is completed, clinician has to ensure the occlusion. If it is out of occlusion, then over eruption will occur, so that tooth will come in harmony with the upper teeth to produce occlusion. The restoration should then be checked in all mandibular excursions to ensure that no interferences have been introduced. 1 or 2 units of extracoronal restorations can again be constructed in a relatively simple manner. This is usually done in the laboratory using handheld models to reproduce the occlusion. Again, great care must be taken at the trying stage to check for the occlusion. Care is also required when restoring the most distal tooth in the arch. It is a bit challenging as well, as it is very easy to introduce errors in this situation. It may be more appropriate to use occlusal records and mount the models on the articulator. More complex laboratory-made restorations may be needed to be constructed with the models mounted on the articulator. Allows restoration to be constructed in harmony with the patient's occlusion in all mandibular positions, which should minimize the amount of time spent adjusting the restoration at the trying stage. So, articulator is a device which holds the models in a particular relationship and simulates jaw movements. Numerous types of articulators are also available, which are appropriate for using crown and bridge work. The articulator must accurately reproduce mandibular movements. To do this, the cast must be mounted in the correct relationship to the temporomandibular joint. This is achieved by taking a Facebook record. In a conformative approach, cast should be related in ICP for restoration. So these all the factors, conformative approach, recognized approach, even the use of articulators if it requires to produce the desired occlusion to the patient post-operatively has to be performed. Though it is a complex and time-consuming procedure, at most aim is to gain the right occlusion post-treatment. Occlusal, what are going to be the occlusal records required to achieve this? Occlusal records are required to mount the models on an articulator in a particular position. Two positions commonly used mounting are intercuspal position or ICP and retruded contact position RCP. A wax squash bite has commonly been used to record ICP, that is the intercuspal position. It is inaccurate as the mandible can be deviated as the teeth bite through the wax. For example, for ICP, it is better not to use any record and to mount the models to the position of best fit. After the preparations have been carried out, it can be difficult to locate the working model to this position of best fit. In this situation, transfer coping technique can also be used. These are constructed on working dies, which are taken to the clinic and seated in place on the preparations. They are then adjusted to ensure they are clear on the occlusion. A further mix is applied to the occlusal surface of the coping and the patient is asked to close their teeth together. This produces an indent on the opposing tooth in the resin and provides a very accurate occlusal registration. When the models are to be mounted in retruded contact position, it is achieved by recording the position of the mandible on the retruded arc of closure just before the tooth contact occurs. It is termed as pre-centric record and generally registered with relatively a hard wax. The record is constructed on the maxillary model and trimmed flush with the buccal surface of the tooth, then softened and seated on maxillary teeth, and mandible is manipulated on the retruded arc of closure indent of the wax without allowing the tooth contact to take place. The registration can be refined by using low viscosity material, temp bond, in the wax record. Alternatively, proprietary interocclusal registration material may be used to record space between the prepared teeth and their opponents. So these are just the methods to for the occlusal records. Just to reproduce the most accurate occlusion, which will be more comfortable to the patient post-operatively. Team working always gives the good results. Likewise, it is essential for the whole dental team, such as dentist, nurse, dental hygienist, therapist, dental technician, as well as to the receptionist, to work together and communicate well for optimum outcomes of the patient and optimum use of individual skills. Four-handed dentistry usually takes an active role by working closely with the dentist. Advantages being it increases the comfort for the dentist as well as to the nurse, increases the efficacy, patient comfort, operator visibility, then reduces the backache to the patient, increases professional satisfaction to the dentist and as well as nurse, overall enhances the outcome. Factors to be taken into consideration while you are having a good team of all the dentist, nurse, hygienist, therapist. So better seating position to the patient. Except for the old, infirm or the pregnant patient, totally supine position is the preferable for most dental examinations and the treatments. Some procedures, such as in case of oral surgery, clinician may prefer to stand with the patient. Patient sat more upright. Always before reclining the chair, it is always advisable to inform the patient. Seating of the dentist, the aim is a relaxed, undistorted, and comfortable posture with a good vision of the teeth to be treated. Adjust the stool so that the top of the dentist's thighs slope at 15 degrees to the floor. Position the dental chair so that with the operator's back straight and patient's mouth is at dentist's focal distance. Forearm should slope upwards to the point and operator's location is between 10 o'clock to 11 o'clock relative to the patient's head. Seating the dental nurse. Also be seated comfortably with the straight back with their eye level 10 centimeter higher than the dentist for the maximum vision. The dental nurse normal working environment is at between 2 o'clock to 3 o'clock within easy reach of the instruments and equipments to be used. The method of instrument transfer is just in front of and slightly below the patient's mouth, not over their eyes. There are several techniques which enable the dental nurse to pass and receive instruments effectively from the dentist. Each dental team needs to choose, adapt, and practice and prefer the system that they safely achieve instrument transfer. It depends on their comfort. Role of dental nurse, mainly in assisting the dentist by preparing and maintaining the clinical environment, carrying out infection control procedures, handling dental materials, recording notes, and processing radiographs. Supporting the patient by monitoring and providing the support, advice, and reassurance. Providing medical emergency support if at all it is required. Isolation and moisture control. Isolation and moisture control is required to protect the patient from caustic materials or aspiration of foreign materials, aid in visibility, prevent contamination during moisture sensitive techniques, and maintain a relatively aseptic environment. So aspiration, in case of high volume suction, aspirators are used. For low volume suction, saliva ejectors. Compressed air tends to redistribute the moisture to somewhere else. For example, to your eye also it might end up rather than remove it. It should be used with a care in deep preparations as prolonged use can cause pulpal damage, let alone displace adhesive materials when the solvent is being evaporated prior to curing. Absorbents such as cotton wool rolls, insert with a rolling action away from the alveolus. Moisten before removal to prevent tearing of the mucosa. It will end up excessively drying of the mucosa and tear it up. Paper pads are also used. Carboxymethyl cellulose pads are also available. These seems to be very effective if inserted the correct way around the impermeable plastic against the tooth. So the very important and key role during the treatment procedures is going to be the placement of the rubber dam should be thorough with it, and a clinician must be well aware about the advantages. It provides effective isolation and also improves access to the operating site. It is indicated where airway protection and moisture control are essential. For example, during the root canal treatment and bonding. With the practice, it can be applied quickly and often saves time in long run. It must be secured to the teeth. Several methods are available. So it provides, so the material required are going to be rubber dam clamps. These consist of two metal jaws linked by one and more bows commonly used for posterior teeth. Floss ligatures, wedges, proprietary rubber bands or wedges or pieces of dam work through the contact points by pinching the dam between the tight contact points. Types of dam. Sheet grade 6 inches square, which is supported with the frame. Moderate to thicker gauges are preferable. Mask type or dry dam, which is supported by a paper margin and looped over ears with elastic. Increasingly, latex-free rubber dam is available and arguably should be used routinely. Optragate, lip and cheek retractors, more anatomically shaped rubber dams are also available. Placement. Several regimes have been described. The following, which one is going to be the popular one? So first, punch the holes which corresponds to the tooth size. This is going to be the first procedure. Cleanly in the rubber dam at the center of each tooth to be included. Trying the clamp with the floss tied to it. So clamp retrieval will be easier and it will prevent the aspiration by the patient also accidentally. Fit the clamp into the appropriate hole punched in the dam with the bridge distally, and using the forceps, place clamp and a dam onto the tooth in the wing technique. Alternatively, the clamp may be placed first and the dam pulled over, wingless. The latter is especially used for broken down teeth or for the poor access cases. Positioning the dam onto the teeth using floss to ease through contact points, then securing the dam anteriorly using one of the methods. If a frame is required in position, put a gauze swab or a napkin on the patient's chin under the dam to prevent a frame digging in. Saliva ejector will add the patient's comfort. If using the caustic material, a rubber dam sealer should also be used. Then the removal of the dam, it takes to begin with, we have to take away the clamps and the ligatures, then stretch the dam, carefully cut the interdental septa with the scissors and then remove it. So removing is going to be less time consuming and easy to perform. Protection of the airway during the placement of the rubber dam is holds very importance. A rubber dam should be used when fitting crowns, bridges, inlays, or the onlays and carrying out root canal treatment, with the exception during root canal. If it is not possible to place a rubber dam, a butterfly sponge or gauze may be used, but airway protection should always be considered. Gingival retraction. It decreases the gingival exudate and exposes subgingival preparations prior to impression taking. Some retraction cords are impregnated with substances such as adrenaline. It decreases the bleeding. The cord should be gently placed into the gingival crevice with the cord packing instrument, leaving no tag hanging out prior to impression taking and temporization. Braided cords are better than the twisted ones. Bleeding from gingival margin can be decreased by applying astringent, which contains ferric sulfate, a paste which expulsi, which contains aluminum chloride, provides for retraction and hemorrhage control. Expezel is useful for preparations finished within or just below the level of gingival crevice. Otherwise, retraction cord is more appropriate. Electrosurgery may be indicated when margin extends subgingivally and gingival overgrowth hampering the restoration placement, or in case of impression taking. Also for crown lending procedures, although bone removal is required. Principles of operative procedures. Why it is required to restore the tooth. So to allow for daily self-mechanical debridement of dental biofilm, for pain relief in case of reversible pulpitis, and to allow the pulpodentinal complex to respond and heal, to restore function, form, and aesthetics, which is utmost, to prevent further spread of an active lesion. So always it is minimal invasive dentistry playing utmost important in case of these procedures, because the morphology of the carious lesion cavity should be kept as small as possible by excavation of only deceased enamel and dentine, the requirements of the restorative material being used. The remaining cavity walls are prepared chemically and physically in a manner appropriate to the material. The final restoration should support the strength and the remaining tooth tissues, promote remineralization, seal any remaining bacteria, and deprive them of their nutritional supply, and predictably restore form, function, and aesthetics is going to be the main goal. General principles of tooth preparation: gaining or widening the access to the caries through enamel using rotary instruments or hand chisels. Cut away all significantly unsupported enamel and demineralized enamel margins, creating a sound enamel margin. Caries infected, which appears sometimes dark brown, black, or soft or wet. Dentine should be removed using low-speed rose head burrs or hand excavators, or even using chemomechanical gels. In smaller lesions with optimal moisture control, some peripheral caries affected, such as which appears light brown, sticky, or scratchy, dentine can be left at the amino-dentinal junction, provided there are no aesthetic concerns. The larger lesions or where moisture control is not optimal, then sound dentine at amino-dentinal junction is essential to maximize the bonding. Small amount of caries affected dentine can be left overlaying the pulp in a symptomless tooth with an achievable peripheral seal if there is a risk of pulpal exposure. Where endodontics is planned, all carious dentine should be removed. Once caries has been removed, further modifications should be made according to the restorative material. It depends the material aspect of these all the endodontic materials, the properties and the procedures to use them, and what are the modifications required during the procedures. All I'll be dealing in another session. For all the materials, an internal line angle should be rounded to decrease the internal stresses. Otherwise, these are the sites of the fracture mainly. Removing caries using large diameter round burr automatically rounding up the line angles. Few helpful points like marking the centric stops with the articulating prepper prior to the tooth preparation. It will help to try to preserve if possible, or place the preparation margins past occlusal contact areas. Avoid crossing marginal ridges when removing caries mechanically. Tactile appreciation of the hardness of the dentine is very important. So always using the instruments in a low speed. Margin should be supragingival wherever possible. Just a classification of dental caries. Will be sharing GV Black's classification of the caries in my free Telegram group during the question answer sessions. So class 1 is the pit and fissure caries, which is the occlusal. Class 2 is the proximal caries of the posterior teeth. Class 3 is the proximals. It involves caries on the anterior teeth. 4 is going to be the anterior incisal edge, and class 5 is the cervical third of buccal or lingual surface of any tooth. Posterior composite restorations. The Control of Mercury Regulations 2017 stipulated there is no use of amalgam in the treatment of the deciduous teeth, children less than 8 years of the age, or in case of pregnant ladies, children with less than 15 years of the age, pregnant ladies with breastfeeding women, except when strictly deemed necessary by the practitioner. It is likely further phasing down will occur, possibly to a complete ban over the years worldwide. Additionally, patient expectations increasingly include nowadays that the tooth color restorations because of the aesthetics. So posterior composite restorations are an established feature of contemporary dental practice. Many dental educators no longer consider amalgam the material of choice for restoring the posterior teeth. But still it is being used, so we are going to deal with it. There is an increased evidence to justify the use of composites in the restoration of the posterior teeth. All new dental graduates should compete in providing posterior composite restorations, which are going to be the near future. Already there. Indications going to be the primary caries lesions in occlusal or the proximal surfaces, core buildups, restoration of endodontically treated teeth, restoration of worn teeth, repair or replacement of failed restorations, restorations extending onto the root surface, which require resin modified glass enamel cement layer in open sandwich technique. So these are the indications for the posterior composite resin restorations. So once we all are aware about what are the indications, the manipulation involves success depends on the effective isolation, then preferably with the rubber dam. Outline form is determined by extent of the caries and the undercuts that are not necessary for the retention. Beveling of the occlusal surface, it would result in composite layer in a load-bearing area which would be prone to fracture. Beveling of the margin of the proximal box is indicated to increase the surface area of for bond, except when little enamel bulk remains or if restoration finishes. Linings or bondings. There is a wide range of commercially available techniques for bonding or basing deeper cavities and lack of consensus as to most suitable techniques. Can use 3-step total edge or 2-step self-etching. Both are available and commonly practiced. Many different matrix systems are available, including metal, single-use, and traditional ones. Transparent matrix bands and sectional matrices. Finishing with the discs, polishing burrs, and the interproximal finishing strips is necessary to achieve excellent marginal adaptation, especially proximally and cervically. So these are manipulations required during performing the posterior composite restorations. Techniques for small cavitated lesions, mainly for the class 1 restoration, composite restorations. Preventive resin restoration or partial resin restoration. Preparation is limited to caries removal and resultant pre-preparatic restored using fissure sealant alone if small, or resin composite followed by the sealant if larger lesions. The rationale of this approach is that adjacent fissures are sealed for prevention. If the preparation extends significantly into the load-bearing areas, then conventional tooth preparation should be carried out and the tooth restored with the resin composite or other suitable material. In case of medium-sized lesions, same procedure such as following the tooth preparation, etching the enamel margins and the occlusal surfaces for 15 to 20 seconds, then wash dry, apply a dentine adhesive system around for 20 seconds, then restore the preparation with the resin composite placed and cured in increments. Polish with the discs, points or cups or using the strips, then removal of the rubber dam and checking for the occlusion, and remove any if high spots are there. For proximal class 2 caries, place a pre-curved metal matrix band and wooden or plastic wedges. For proximal caries, this is the initial step before beginning with the treatment procedure. Then etching the enamel margins and occlusal surface for 15 seconds, similar to other procedures. Wash and dry, applying the adhesive system for 20 seconds, then restore the preparation with resin composite, placed and cured in increments. Same, the polishing with the rubber, with the discs, points and cusps or strips, removal of the rubber dam and checking for the occlusion. Any high points remaining have to be removed. Few key points to be taken into consideration for the resin composite restoration, such as using etch and gel in a syringe aid in placement. Usually they are available in syringe form. Many newer adhesive systems do not have a separate etch stage, however, and rely on the use of acidic primers, often used in conjunction with bonding resins or as a separate stage. Additions are generally easy as new resin composite will bond to old one. Avoid eugenol containing cements with resin composite restorations. These must be cured incrementally, not in a bulk, with increments being not more than 2 mm deeper. Pre-wedging one but not both proximal contacts aids in creation of contact point. If possible, centric stops should be preserved on sound tooth tissue or the restorative material, but never on the marginal interface of the restoration. It will tend to fracture. As the inlays are bonded to the tooth with an adhesive, parallel walls are less important, but undercut must be removed or blocked out. In general, porcelain inlays offer improved aesthetics, surface finish, and bond in comparison to resin composite inlays. However, placement and adjustment can be more difficult. Direct posterior resin composites may not perform so well in cusp replacements, poor moisture control, restorations with deep gingival extensions, although a bonded base approach can be adapted, bruxism or heavy occlusion. So these are going to be the drawback of the posterior resin composites. Indirect resin composites or porcelain inlays or the onlays. These inlays or onlay techniques appear to overcome some of the problems associated with direct resin composite restorations. Onlays provide cuspal coverage, which we cannot use the posterior composites for the cuspal coverage. Inlays do not. As inlays are wedge-shaped preparations, they do not resist tooth fracture but may in fact predispose to fracture. Curing resin composite outside the mouth in the manufacture of resin inlays or onlays with an addition of heat that is up to 110 degree for 5 minutes or pressure overcomes the polymerization shrinkage and possibly increase the strength. These are the advantages of indirect resin composite or porcelain inlays or the onlays, just to overcome the drawbacks of the posterior resin composites. Technique of preparation, it includes preparation should have a slightly divergent walls, rounded line angles, and slight bevel of the enamel margins, but not occlusally. For onlays, a minimum 1.5 millimeter reduction of cusp is necessary, blocking out all the undercuts, taking the impression of the preparation and opposing arch if necessary, make an intercuspal interocclusal record. Choose a selection of the shade and make a place for the temporary with a proprietary resin-based temporary material. The most commonly used ones I have mentioned in the brackets. It may vary depending on the location. So the cementation of the inlay or the onlay involves followed by a placement of a rubber dam, remove temporary any restorations present and cleaning the tooth. Be careful not to alter it during the removal of the temporary and restoration and cleaning it. Trying inlay or onlay and carefully check for the marginal fit and adjustments if any required has to be performed. Polish any adjusted areas, remove inlay or onlay and clean with the alcohol. For porcelain only, place layer of silicone silane coupling agent on fitting surfaces. Etching the enamel and the dentine, total etch concept is followed. Then wash and remove the excess moisture, but do not over dry it. It will lead to the brittleness. Place dentine adhesive system to moist surface for around 20 seconds, same as the previous one. Also apply to the restoration fit surface if recommended. Apply dual cure resin composite luting cement to prep and inlay and carefully seat it. Remove gross excess cement and then cure for 10 seconds and remove any further excess is there. Complete light curing. Dual cure resin composite will finish setting chemically under inlay approximately 6 minutes. Then trim any excess cement and then polish it, especially interdentally. Then removal of the rubber dam, check occlusion and adjustment has to be done. These are just the sequence of events to be followed while performing the indirect resin composite or porcelain inlays or the onlays. In case of posterior amalgam restorations, if enamel margins are cut to an angle of 90 degree, excuse me, or if the cusp is steeply inclined more than 70 degree, the resultant preparation will be adequately retentive. Proximal preparations comprise proximal box with vertical grooves. The preparation should only extend occlusally if there is evidence of caries in the occlusal fissures. Retention from occlusal force is derived from a 2 to 5 degree divergence of the walls towards the floor in both the parts of the preparation. These are just the factors to be taken into consideration while dealing with the amalgam restorations. These are usually prone to fracture at the isthmus of the restoration, which is the very important factor to be taken into consideration if it extends occlusally. Therefore, sufficient depth must be provided in this area when using the amalgam as the restorative material in case of posteriority. The width of the isthmus should not be overcut, ideally 1/4 to 1/5 of the intercuspal width. If the cusps are extensively undermined or missing, they should be replaced with a bonded restoration. A chisel or burr can be used to plane away the unsupported enamel from the margins of the completed preparation to produce 90-degree butt joint. In molar teeth with the mesial and distal caries, it is preferable to try and cut two separate cavities, but often a confluent mesio-occlusal distal preparation is unavoidable. Increasingly, the use of resin composite placed in conjunction with the dentine adhesive system is advocated for the restoration of the premolar and the molar teeth, even if the amalgam is the material of choice going to be, then these factors are mandatory to be looked for. So the size is usually determined by the size of the carious lesion and extension beyond. This should be minimal. So till now we have dealt with this restorative dentistry of repairing of the teeth. In next session, I'll be covering the anterior and proximal caries, management of extensive or the deep lesions or restorations, survival and failure of restorations, tooth wear, veneers, anterior crowns, post and core crowns, anterior post and core crowns, and temporary restorations. Very soon we'll announce the date. This is our contribution in your MFDS Part 1 study journey. So I would like to conclude, if you can dream it, you can do it. CM Dental Academy is always there to help you for any queries, discussion of topics, or any doubts. You feel free to discuss in our free Telegram group. We'll be posting the MCQs related to this topic shortly in the group. Thank you for your overwhelming response. Would appreciate if you share the feedback. Thank you.